So what's different about pediatric migraine than adults? Well, first of all, the headaches are often briefer. You know, by criteria, we say 2 hours or more, but I've got a lot of kids who will have headaches for 30 to 45 minutes, and they're migrainous headaches. And I call it a migrainous headache. Does it fulfill criteria? No, but it's still a migraine. You know, they got a family history, they've got typical features. It's a migraine, it's just briefer. They're often bilateral. We don't have unilateral headaches in kids very often. They may or may not have light and noise sensitivity. They may or may not have nausea. Sometimes their headaches are occipital, or sometimes it's occipital and you got to worry about something like a Chiari malformation. And if I see somebody who's always having occipital headaches, I'll frequently image them, because with or without neck pain, with or without back pain or other focal findings, you know, we often pick up on Chiari malformations in that population. Christina, I think, showed you this earlier. I think this is a great screener, ID Migraine. Richard Lipton published this back in, I think, 2005 or something, long time ago. It was 2004. So super easy. Making a diagnosis of migraine is so easy. Do you have nausea? Do you have light sensitivity? Do you have to stop what you're doing? Does it disrupt activity? So a quick, easy screener. What about incidence of migraines in kids? And we've already alluded to this. Migraines are common in young people. In pre-adolescence, it's more common in boys, and then when puberty kicks in and we have hormonal changes and fluctuations in estrogen, incidence goes up dramatically in girls. So adolescence is a very common time for us to see migraine headaches in girls. If you look at adult women who have migraine headaches, about a third of them develop migraines during puberty because of hormonal changes. And if you look at adults who have migraines, about 70 to 75% of women have migraines during their menstrual cycle because of hormonal changes. So these are things to watch for. Management, I think, you know, management is easy if you can get the patients on board. And a lot of it is, I think, is just about education and lifestyle modifications. So I think medications can be helpful, but frequently medications aren't even necessary in the pediatric population, because a lot of times we can change just their environment or how they're taking care of themselves and really make a big difference in migraine. And that takes talking to the family and talking to the kids and getting them on a regular regimen. So again, I think probably the most important thing is, from a family standpoint, a lot of families, all they care about is knowing that their kid doesn't have a brain tumor. That's why they come to see you with their kid, because they're concerned their kid has a brain tumor. You have to give them a credible diagnosis. And I tell them flat out, this is migraine, your kid is fine neurologically, he's healthy, but we have to treat the migraine headaches. We talk about a genetic basis, because this is often familial. I talk briefly about pathophysiology of migraines, but I try to break it down to a level where, you know, the general population can understand. I tell people have migraines, their brains are sensitive, their brains are hyperexcitable, they respond differently to stimuli. And I think people kind of get that a little bit. We talk about sleep and eating and dehydration and stressors and things like that can impact on headaches, and ultimately identifying potential triggers for headaches. And then, of course, everybody wants to delay treatment. I don't want to treat my headache until it's bad. I don't want to take anything soon. And you have to break that cycle and get them to treat earlier, because then they do much better.